about the different forms of tuberculosis. We said that tuberculosis is usually contracted as a pulmonary disease. It doesn't have to be, but most of the time it's contracted as a pulmonary disease. One contracts the organism by inhaling some sort of droplet that's contaminated with the organism. The organism gets in the lungs, starts to proliferate in lungs, colonizes the lungs. Now, the body's reaction to the infection really determines a lot of the presenting features of the infection. And based on how your body reacts to the organism, we can subclassify TB into a number of broad categories. There's primary TB and there's secondary TB. Important thing to remember about primary TB is it's a set of features that presents in an individual whose immune system has never been sensitized to the antigens of this organism before. The person's immune system is completely naive to the organism. And when your immune system sees this organism for the first time, it generates a series of reactions to the organism that culminates in a presentation we refer to as primary TB. Then we've got something called secondary TB. Secondary TB is simply a spectrum of symptoms, a spectrum of features that develops in an individual who becomes infected with the organism, and their immune system has already been sensitized to all the antigens of the organism. And so usually the immune system responds very vigorously to the organism. And as a result of this vigorous response to the organism, the presenting features of a secondary TB infection are a little different from that of a primary infection. And so those spectrum of symptoms that develop is called secondary TB. It's a set of features that develops in individuals whose immune system has already been sensitized to the antigens of this organism. So we got primary TB, we got secondary TB, and that is the main difference, whether or not your immune system is naive to the organism or has already been sensitized to the organism. Okay, let's talk a little bit about primary TB first. Primary TB, again, a set of features develops in an individual whose immune system is naive to the antigens of the organism Mycobacterium TB. Let's take a look at generally what happens. Again, typically the organism is contracted as a result of inhaling some sort of droplet that contains the organism. The organism gets down into the lung. It lodges somewhere in the lung parenchyma. It begins to proliferate. Initially, it's going to trigger it's going to trigger an acute inflammatory response, but eventually that acute inflammatory response is going to turn into a caseating granulomatous inflammatory response. This organism is one of the few organisms that triggers a granulomatous inflammatory response. That's important to remember. Granulomatous inflammation. Now, this focus in the lung where the organism is growing creates a granulomatous inflammatory response that turns the lung into kind of this white cheesy material. And this little focus in which in which this organism is growing is referred to as a GON focus. Let's take a look. Here's a section through the lung. We're looking at the hilar region lung. There's the apex, there's the base, there's the hilar region right there. Okay, you can see some normal lung parenchyma out here. This person's a cigarette smoker. Okay, you can see the anthracosis very clearly. All that's relatively normal lung. When the organism infects this lung, it generally lodges in a focal area of the lung, begins to grow, and incites a chronic granulomatous inflammatory response that turns the area into a cheesy material due to chronic granulomatous inflammation. And if you look over here, you can see an area of white discoloration. That area is the area of caseating necrosis. We call that a GON focus. A GON focus. That's where the organism is growing. Now, this area of infection generally is drained by lymphatics. Lymphatic system will drain a lot of the debris to the hilar regions of the lung. And along with the debris, you'll have some viable organism from that area will also drain into the lymphatic system and be brought to the hilar lymph nodes. And the hilar lymph nodes will become infected as a result of all these viable bacilli being drained through the lymphatic system. when the lymph nodes are involved and this area of focus, the GON focus plus the lymph nodes develop. The focus plus the lymph nodes are involved in this granulomatous inflammation. We call the two collectively a GON complex. A GON complex. GON complex refers to the GON focus as well as the involved lymph nodes. Let's take a look at those lymph nodes. That's a normal lymph node right there. You can see it's kind of a pea-sized organ, kind of brown because it has a lot of carbon dust in it. And over here, you can see these areas of white discoloration. Okay, that is a lymph node that has been infected with the organism, and its architecture has been completely effaced with chronic granulomatous inflammation, turning the material into kind of a cheesy, kind of white cheesy material. And that is an infected lymph node. Collectively, the GON focus and the infected lymph nodes are referred to as a GON complex. A GON complex. Now, there are a number of possible outcomes of infection like this. Most of the time, the infection remains fairly asymptomatic, but there are some other possibilities. Let's take a look at these lymph nodes that are involved. Take a section through lymph node. Here's what an infected lymph node looks like. Okay, you can see we've got an area of caseation here. Area of caseation surrounded by multinucleated giant cells here. And those multinucleated giant cells are surrounded by a lot of lymphocytes. And you recognize that architectural arrangement of white blood cells is chronic granulomatous inflammation. We zoom in on this area. Again, you can see the area of caseation. There are the multinucleated giant cells. These are actually fused macrophages, and those in turn are surrounded by lymphocytes. This type of inflammation is called necrotizing or caseating chronic granulomatous inflammation that characterizes this type of infection. Now, again, there are many possible outcomes to an infection like this. Best possible outcome, and indeed the most frequent outcome in an infection like this, is the infection remains completely asymptomatic and the person otherwise have actually been infected. Usually, these areas of caseation will heal with minimal scarring. It will probably be so small they won't even be detectable on the chest radiograph. And so the outcome is completely asymptomatic, and there's no visible evidence, at least on a radiograph, that the person's ever been infected with tuberculosis. That's the best possible outcome. That's the most frequent outcome. Another possible outcome, person infected with TB. The immune system attacks the organism with the chronic granulomatous inflammation, but surrounds the organism with a fibrous enclosure. And this fibrous enclosure will subsequently calcify. The result is a fibrocalcific nodule. Within this fibrocalcific nodule, there may be some dormant, but nonetheless viable organisms that could reactivate at any time. This results in what we call a latent infection. A latent infection. Now, the fibrocalcific nodule is visible on a radiograph. Looks like this. This is an example of a fibrocalcific nodule developing in primary TB. And we're looking, of course, at the left lung field, cardiac silhouette here. Look in the apex of the field, you can see this radiodense nodule. That is the fibrocalcific nodule. Within that nodule may be some dormant but nonetheless viable organisms, and those organisms may remain dormant for the rest of the person's life. It's also possible that sometime in the future, these organisms could reactivate and reinfect the lung. Whatever be the case, these organisms are within that fibrocalcific nodule, creating what we call a latent infection. A latent infection means it's an asymptomatic infection until possibly some other time the infection reactivates and it causes some sort of symptomatology. But this is another possible outcome of a primary TB infection. A latent infection in the form of a fibrocalcific nodule. So far we talked about two outcomes: asymptomatic with no trace of infection, and two, a fibrocalcific nodule, creating what we call a latent infection. A third possible outcome of a primary TB infection is that the immune system is incapable of containing the infection, and the infection spreads throughout the entire lung, destroying a lot of lung parenchyma. This is what we call progressive primary TB. People with progressive primary TB are very symptomatic. When you think of TB as a horrible disease, it's these people with progressive primary TB that are the ones you're thinking of. They're very symptomatic. They're coughing up a lot of blood, a lot of sputum, a lot of necrotic material. Okay. The organism can't be contained by their immune system for whatever reason, and it spreads throughout the entire lung. We call that primary progressive TB. Okay. Very often, unless it's treated, primary progressive TB will result in a complete destruction of the lung parenchyma. There's another possible outcome. Person develops primary progressive TB, the organism can get into the bloodstream and disseminate all over the place. That's called primary miliary TB, or primary disseminated TB. The organism goes all different places. It can go to meninges, it can go to the spleen, it can go to the liver, it likes to go to adrenal gland. It disseminates all over the place. That's called primary miliary TB, also known as primary disseminated TB. Now, usually primary miliary TB or primary disseminated TB only occurs in people who are immunocompromised. Most of the time, as I said before, people are infected. They are none the wiser than they're infected. The organism is completely destroyed without the person even knowing they've been infected. Second thing, you get a latent infection. The immune system walls off the infection, and the fibrotic enclosure that subsequently calcifies causes a fibrocalcific nodule. Within that nodule, you may have some dormant but viable organisms, and that creates what we call a latent infection. Again, the person's usually completely asymptomatic, with the exception of the fibrocalcific nodule that you see on radiograph. Another outcome, primary progressive TB, the organism spreads throughout the lungs, destroying the lungs. People are very symptomatic with primary progressive TB, coughing up a lot of sputum and necrotic tissue. And then from there, if they're very, very unlucky, the organism can get in the bloodstream and disseminate. Primary miliary TB, primary disseminated TB. Okay, people with those diseases are usually somehow immunocompromised. Okay, any questions on those outcomes? Yes.
Not about the fibrocalcification on this image, but the other white little foci. What would you say those are? You see them on chest X-rays sometimes.
These?
Yeah, like all little white dots.
Those, I'm taking a guess. Those can be focal granulomas as well. They're just not that big. Focal granulomas. But you guessed it.
What? No.
No,
It's nothing.
no. Okay.
I have a quick question. So, so the first outcome, it just nothing really happens? Is that what
Nothing
you're
really
saying?
happens.
Okay.
That's the most frequent, best possible outcome. And there is absolutely no radiographic evidence the person ever was infected. Yes.
With progressing, can it ever progress to both lungs, or is it just?
It can progress throughout the entire lung, right and left. Okay, now I'm going to show you a little more about that in a few minutes. All right, let's talk a little bit about the workup. Most of the time, the person with TB is discovered to be infected with TB incidentally. Either they get a PPD test, the routine PPD test, which is positive, or they get some sort of incidental radiograph and they see some sort of fibrocalcific nodule. And most of the time, the discovery is incidental. Again, in fulminant disease, fulminant meaning very progressive, very unstable, such as primary progressive TB or biliary TB, those people are very symptomatic. Now, usually the screening test for TB is the PPD test. You're all familiar with the purified protein derivative test. Have you talked about that? No, you have not. Okay. So this is, there are many variations in the PPD test. This is a test in which we isolate some of the antigens of Mycobacterium, the Mycobacterium genus, and we inject it underneath the skin. Now, if an individual's immune system has been exposed to Mycobacterium before, person will react to these antigens that are injected under the skin. Usually what will happen is a very large erythematous patch will swell up, okay? And this will be what we call positive PPD test, meaning the immune system has seen those antigens and is clearly reacting to it. If, however, the person's never encountered a Mycobacterium organism before, you inject those purified protein derivatives underneath the skin, the immune system won't react to it. You won't have any kind of erythematous patch that develops, or papule or patch that develops in that area. That's what we call a negative PPD test. PPD test is a way we generally screen for exposure to the organism Mycobacterium TB. There are a variety of other tests. I won't go into it now, but in my microbiology class, I do go through something called the gamma assay. If you've ever heard of that one, gamma interferon assay. Any questions about primary TB? Okay, let's talk about secondary TB. Secondary TB, again, a spectrum of symptoms that develops in individuals who contracts the bacterium for a second time. Their immune system's already sensitized to the organism. So now when they contract this infection the second time, the immune system skips a lot of the acute inflammation, goes right to attacking the organism with granulomatous inflammation, very vigorous response. It's already sensitized to the organism. It doesn't have to process any of the antigens. And so the response is usually very quick, very vigorous. Now again, with secondary TB, the most likely outcome, nothing. Person gets infected a second time, not even aware they've been infected a second time. And again, no radiographic evidence most of the time that they're infected a second time. The immune system takes care of it very quickly. Sometimes, however, the immune system is overly zealous in the way it attacks the organism. And the immune system attacks the organism. Not only does it take out the organism, but it takes out a lot of lung parenchyma as well. And there's extensive caseation and cavitation, particularly in the apices of the lungs. Let's take a look at this. Here's an example of one of the possible outcomes of secondary TB. And we have a section through the lungs. There are the bases of the lungs, the apices of the lungs. Okay. Down below, you can see the cut surface of normal lung and a bit of a smoker, but otherwise a normal looking lung. Okay. Visceral pleural looks good. Lung parenchyma looks good down below. In the apices of lungs, however, you see a lot of cavities. And you see a lot of white material. That's all caseation. That's necrotic tissue. That's caseous necrosis. This type of appearance of lungs is caused by an overly zealous immune system attacking the organism. The organism's already been processed by the immune system. Immune system will launch a vigorous response when it sees it a second time. Most of us will keep that secondary response in proportion to the infection. Again, the organism will be wiped out with no significant damage to the lungs. However, other individuals, their immune system is overzealous, takes out the organism, and it takes out a lot of lung parenchyma as well. This type of caseation and cavitation is rather unique to secondary TB. And again, this only happens in a subset of individuals who've been reinfected with TB. Most of the time, your immune system handles the infection perfectly in proportion. Person never knows they're infected. Everything is fine. Then the immune system can do this, overzealous reaction. There are some other possibilities. Sometimes the person's immune system somehow has been compromised. The immune system is incapable of keeping the organism in check. If that's the case, then the person will develop what we call secondary progressive TB. The organism will spread throughout the lungs, again, destroying the lungs. Let's take a look. Here's an example of progressive secondary TB. It's a chest radiograph of someone with AIDS. developing TB for a second time. And again, you can see the cardiac silhouette, the lung fields. Lung fields look fairly lucent, but you'll see there are these kind of meager looking infiltrates throughout the entire lung. Some of it looks like airspace disease. Some of it looks like interstitial disease. Okay. This is an example of a radiograph in which the organism has been allowed to spread throughout the entire lung. The immune system is not keeping the organism in check. It's trying to launch an inflammatory response against the organism, but the infiltrates are really small, meager. These lungs should actually be completely whited out. They should be filled with some sort of exudate, some sort of inflammatory infiltrate. If the organism were this widespread, but because this person has AIDS, the immune system is not launching a vigorous response against the organism. The organism is spreading throughout the lungs, spreading virtually unchecked by the immune system. This is what we call progressive secondary TB. And again, person like this, very symptomatic. Eventually, the lung is going to be completely destroyed. Probably coughing up sputum. They're going to be coughing up a lot of necrotic material as well. Again, in a person who's immunocompromised, they can further have trouble. The organism can get into the bloodstream, disseminate all over the place. And again, the favorites: meninges, adrenal gland, liver, spleen. The organism likes to go to these different organs. Let's take a look at what miliary TB looks like when it goes to the spleen. First, let's take a look at a normal spleen. There's a normal spleen. Cut surface, normal spleen. There's the splenic capsule. And you can see lots of blood vessels going through the spleen. Lots of normal splenic parenchyma there. Everything looks good. If that's what normal spleen looks like, here's what miliary TB looks like to the spleen. Again, section through the spleen. There's the splenic capsule. And you can see the cut surface of the spleen is remarkable for all of these little white dots. Each one of those is a colony of Mycobacterium TB. So the organism spreads everywhere. Again, favorite: spleen, meninges. Again, these people are very symptomatic. Okay. Any questions about secondary TB? Yes.
So an example of secondary TB where the immune system attacks the lungs itself. What are the regenerative capacities of the lungs?
The lung does not have good regenerative capacity. The architecture of the lung's been disrupted. The epithelium can regenerate. A lot of different cellular components can regenerate. But if the architecture is altered, that can't be regenerated. And in this case, the caseated necrosis will liquefy the architecture.
So in the case of the secondary TB, that's going to be like, they're going to have lifelong.
They'll have, if they survive, they'll have cavities in the upper apices of the lungs. Typically, the organism likes to colonize the upper apices lungs. The oxygen tension is greater there, and the likelihood of ending up there is greater. If they survive, then that part of the lung does not have the same gas diffusion capacity as the rest of the lung. And those cavities, from time to time, can become colonized by fungus. Fungus likes to grow in those cavities. Even if they're perfect, somehow their immune systems are restored, everything else is fine. So there's some problems with those cavities that develop.
Dr. May,
Yes.
so quick question. So just differentiating between the two. So primary is in people that have never been exposed.
Never been exposed.
And then is the granulomatous inflammation the same for secondary?
Granulomatous inflammation, that's the type of inflammation this organism triggers,
Okay.
both in primary and secondary TB, assuming a person's immune system is functioning normally.
And then it just says lymph nodes not as involved in secondary TB.
That's because of the vigorous response. The immune system tends to keep this organism very isolated in a secondary TB.
Okay.
Yes, a reinfection.
Okay.
Doesn't get to disseminate. That, of course, assumes that the immune system's working properly. Now, there are a couple of variations of things, but I'll discuss that at the end. Okay, workup for secondary TB. Again, sometimes it's just simply based on the history of having primary TB. There could be some radiographic evidence of consolidation, cavitation in the apices of the lungs. That's a hint that the person has secondary TB. Bacilli can be identified in people coughing up a lot of sputum. In each case, when a person is suspected of having TB and they're very symptomatic, we'd like to get a sample of the sputum so that we can culture the organism. The organism is extraordinarily difficult to culture in vitro. It takes about 25 weeks to culture this organism or more. The organism doesn't grow very quickly. Obviously, we can't wait for the culture results before we start treating. We'll start empirical antibiotic therapy. The advantage of getting a culture is that eventually you can test the organism for antibiotic resistance, which tends to be a problem with Mycobacterium TB. So when you're treating this condition with antibiotics, usually you treat with no fewer than 3 different antibiotics. You cover with 3 different antibiotics. The likelihood of a strain developing that's resistant to one antibiotic is pretty small. And so we give a lot of antibiotics just to prevent the resistance from developing. Then once you have the culture, you can further test, further refine your antibiotic therapy, see which antibiotic is the best for the particular strain you have. Okay, but you have to wait a long time for it, but there might be advantages to doing that if the person doesn't respond well to antibiotic treatment. Okay. Let's take a look and summarize some of the different symptoms and profiles of these different forms of tuberculosis. Here we have a graphical depiction of some of the different features of TB as a function of immunity as well as time. Again, typically the infection will start off as some sort of respiratory infection. Someone inhales a contaminated droplet. The droplet will carry some of the organisms to the lung parenchyma. They become lodged in the lung parenchyma. They grow as what we call a Gone focus, inciting chronic granulomatous inflammation and along with it caseation. That's called a Gone focus. Eventually, the lymphatic system will drain the organism to the lymph nodes, where the lymph nodes become infected with the organism. Once the lymph nodes are infected with the organism, the Gone focus along with the infected lymph nodes are collectively referred to as a Gone complex. Again, a couple of possible outcomes of an infection like this. Most of the time, the organisms are completely destroyed. There's absolutely no evidence, even on radiograph, that the person was ever infected. To actually go looking for evidence, you have to do an autopsy and look very carefully at the lung parenchyma. So most of the time, you see absolutely nothing on a radiograph. Okay? Everything is asymptomatic. Another possible outcome of a primary TB infection is that the organisms are sequestered in a fibrous enclosure, which subsequently calcifies, and that results in a fibrocalcific nodule. Inside that fibrocalcific nodule, you may, not necessarily true, but you may have dormant but otherwise viable organisms. That creates what we call a latent infection. That infection may remain dormant for the rest of the person's life, never give that person another problem, or at some point in the future, the organism may reactivate and reinfect the lung. If that happens, the person will develop secondary TB. There's still some other possible outcomes. The person's immune system is odd or for some reason cannot otherwise handle the infection. The infection spreads throughout the entire lung. That's called progressive primary TB. Okay, again, these people are very symptomatic, coughing up sputum, coughing up blood. It's thought that the legend of vampires actually comes from people with progressive TB. You know, they have blood dripping down their mouth, sides of their mouths. And that's possibly due to some sort of progressive form of tuberculosis. From there, the organism can get into the bloodstream and disseminate hematogenously. We call that miliary TB. Can go to the liver, can go to the spleen, can go to meninges, adrenal gland. Those are some favorite sites of dissemination. That's primary TB. Secondary TB, that's a reactivation of an infection or reinfection. Possibly someone could acquire the infection again from an exogenous source, or perhaps some of these lesions in this, some of these organisms in the fibrocalcific nodule, which were otherwise dormant, can become reactivated, reinfect the lung, cause secondary TB. Again, there are a couple of possible outcomes. One of the possible outcomes, not shown here, but could be complete resolution. Again, completely asymptomatic. Okay, no symptoms at all. Okay, still, other possible outcomes. The immune system, with its very vigorous response, can take out the organism with lots of lung parenchyma at the same time, in which case you get extensive cavity and caseation in the apices of the lungs. This person would be symptomatic. They'd be coughing up a lot of necrotic material. Again, something else happens to the immune system. The organism can spread through the lungs, resulting in what we call progressive secondary TB. Again, that person too will be very symptomatic, coughing up a lot of sputum and organism, necrotic debris, and still further, the organism again can get into the bloodstream, disseminate elsewhere, causing a disseminated secondary miliary TB. Secondary miliary TB. Okay. So this is the possible outcomes of a TB infection. Many possibilities. TB is often very confusing to people because there are so many possible outcomes. There are also several other variables that can influence the outcome of a TB infection. Hey, we said primary TB happens to an individual whose immune system is naive to the organism. Secondary TB occurs in an individual whose immune system has already been sensitized to the organism's antigens. Sometimes, though, a person who has already had a TB exposure and the immune system has already been sensitized can lose that memory, that sensitivity to the organism. For example, someone contracts primary TB when they're healthy, develop primary TB with absolutely no symptoms at all. However, if they acquire HIV, develop AIDS, they may lose the memory of that infection. Their immune system may lose memory cells that allow them to retain the memory of that antigenic profile of the organism. And as a result, if they are infected with TB for a second time, they don't develop secondary TB. They develop the features of primary TB for a second time. That's because their immune system has lost the sensitivity, the memory of those the antigenic profile of the organism. So if that happens and they acquire TB for a second time, they're going to develop primary TB. Also, if a person has had a vaccine, the BCG vaccine, the TB, the vaccine is designed to train their immune systems and sensitize the immune system to the organism's antigenic profile. And as a result, if they've been vaccinated and they acquire a TB infection for the first time, what do you think they're going to develop, primary or secondary? They're going to develop secondary TB, even though it's their first infection. Their immune system is already trained to recognize those antigens. So there are lots of different variables, lots of possible outcomes of a TB infection. That's what makes this rather confusing. Okay, any questions on that?
The vaccine of that thing?
We don't use it in this country. Frankly, a lot of studies have shown it's not very protective. It seems to actually be the BCG vaccine seems to be more protective against another type of mycobacterium infection, Mycobacterium leprae. It doesn't seem to work very well for TB though.
What's leprae caused?
Causes lepromatous leprosy.
Oh,
Dr. Mary, is the causation like a cell itself, like the neutrophil, like every lymphocyte inside and becomes like a cell, a round cell? I'm kind of not sure.
The fibrocalcific not?
Cassation. Cassation.
Caseation,
Yeah.
caseation. That just means, that's a type of necrosis, caseation.
So it's not like a cell.
No, caseation just means cheesy necrosis. A cottage cheese necrosis.
But the way you describe, like on the notes, is that what you described? Had the lymphocytes, the neutral.
Oh, you're referring to a granuloma.
So you,
A granuloma.
that's
So the granuloma is here.
so that's-
This is the lesion that creates the caseating necrosis. So there's the caseation within the granuloma. That pink stuff,
gotcha.
there it is right there. That's the caseation.
And that one that I saw in X-ray is which one? That one. Okay.
That is probably inside. You've had extensive caseation. This will sometimes be hollow. It's just kind of a shell that's fibrocalcific.
So the neutrophils and
Sorry.
lymphocytes inside of them.
There may be nothing inside. There may be some dormant organs inside, organisms inside, excuse me. The organisms may be just dormant, but they can be reactivated. They're still viable. They're just not active. Any questions on that? Okay. Case. Let's talk about some fungal infections. Okay, some of the pathogenic fungal infections. We're gonna study one of several fungal infections. We'll take a look at histoplasmosis caused by histoplasma. Okay. This is an organism that can also infect the lungs and cause a caseating granulomatous inflammation. And as a result, sometimes this disease, histoplasmosis, is confused with Mycobacterium TB. It causes the same type of infectious pattern, same type of inflammation. And so very often histoplasmosis is confused with Mycobacterium TB. But this, of course, is a fungal infection. Generally, it is an infection that results from the inhalation of spores from the mycelial form of this organism. Now, you recall that fungi generally are dimorphic. Do you remember dimorphism with fungi? And they have generally two forms. They grow in this kind of branching form like this. Okay, this is called the mycelial form. Mycelial form, and then they can grow as kind of a unicellular organism. This is known as the yeast form. Remember this. Okay. Well, generally, this organism grows in its natural environment, soil enriched with some sort of droppings, and it's the mycelial form. Typically, it grows in caves where there's a lot of bat droppings, and this organism produces a lot of spores. And these spores are very large. They're aerosolized. We generally inhale them. When the spores get into our lungs or a nice, warm, moist environment, they germinate. And when they germinate, they rupture and they release little endospores that eventually develop into the yeast form of the organism. And it's the yeast form of this organism that grows in hard tissues should we become infected. Okay. That's what happens with histoplasma. Now, it is very common for histoplasma to grow in various caves that are, again, rich with droppings like bat droppings. And as a result, histoplasmosis is also referred to as cave disease. Now, it's endemic in certain areas, Ohio, Mississippi River valleys. Those are areas where you typically find the enriched environment which these mycelial form of the organism can grow. Generally, when a a normal individual, an individual with a normal immune system, the immunocompetent immune system, contracts this infection, generally nothing happens. Okay? Person's completely asymptomatic. However, people who are immunocompromised or people with a kind of an odd immune system, they tend to develop problems. Okay, let's take a look at the spores that are produced by this organism. Okay, here's an example of a cytospin. This is a specimen that we've obtained from someone's lungs. You can see that the specimen's full of these spores. These spores are very durable, dormant form of the organism. They each contain hundreds of little endospores. You can see as these little black dots. Typically what happens is that the spore is inhaled. Again, it lodges in the lung parenchyma somewhere. It incubates for a little while. Then the spore breaks open and dumps out all these little endospores. These are the endospores that develop into the yeast form of the organ, the unicellular form of the organism. Now, again, most of the time someone's infected, the outcome is just completely asymptomatic. Person's infected, but there's no disease to develop. Okay. In other instances, people may develop some mild flu-like symptoms. And in still other cases, particularly those who are immunocompromised, can develop a type of progressive disease with the lungs and even disseminated disease. Most of the time, if someone's going to develop any kind of complication with histoplasmosis, they're either going to have something wrong with their immune system, something's going to be a little odd about their T-cell mediated immunity, or they're going to be completely immunocompromised, like someone with HIV or AIDS. Okay. Now, I mentioned that very often this infection is confused with tuberculosis. It incites a chronic granulomatous inflammatory response. It even disseminates to other organ systems and mimics TB in a variety of different ways. Histoplasma can also disseminate to other organ systems. There's an example of a section through liver. You can see we've got a number of hepatocytes here in the section. Amongst the hepatocytes, you can see these little phagocytic cells. Okay. If you look inside the little phagocytic cells, you can see the yeast form of the organism. Okay. This is where the organism gets its name, where the disease gets its name. Histoplasmosis grows in a histiocyte, a phagocyte, a macrophage. Macrophages are also known as histiocytes. That's where the name of the disease comes from. Histoplasmosis grows in these little histiocytes. Now, again, a lot of clinicians can be confused as a result of the similarity in the patterns between this disease and tuberculosis. How do you tell the difference? Well, there are a number of different tests. Certainly, if you can isolate the organism, identify the organism's spores or chlamydia, that will help. You can identify the yeast forms of the organism, that'll help. If you can see these histiocytes with the organism inside, that will help certainly make the diagnosis. Other ways you can test for exposure to histoplasma. You can use a histoplasma skin test, which is similar to the PPD test, except we use antigens of histoplasmosis or histoplasma. You can also stain for the organism. The organism stains very darkly red with a PAS stain, a periodic acid skip stain. It's kind of a glycogen stain. Stains the organism very brightly pink red. Also, if the person has disseminated disease, antigens are filtered by the kidneys to wind up in the urine, and you can test for the presence of antigen in the urine. These are some of the different ways that you can diagnose this condition, okay, and differentiate it from Mycobacterium TB. Any questions on this?
You said this is the same thing of the cave disease?
This is also known as cave disease.
So they can look at this and see the histiocytes and be able to determine it that way.
This
Like
organism
CNS?
tends to grow in the histiocytes, right?
So just looking at that, they'd be able to differentiate
Under
them.
the right, yes, on the right clinical symptoms, right history, if they see that, I
Yeah.
mean, the diagnosis is practically a gimme. And the question is, they'd have to go this far if, they would have to see these histiocytes. actually from the diagnosis. Usually you wouldn't go this far.
Yeah.
You diagnose it based on a sputum sample or something like a histoplasma skin test.
Mhm.
Did you say this is a fungus?
Histoplasma capsulatum is a fungus. Yes.
And people confuse with TB?
They confuse the symptomatology with that of mycobacterium TB infection. That's because both trigger a chronic granulomatous inflammatory response.
So I got a question. How about a sample question of how you would word this compared to TB?
Okay,
You're welcome.
so which of the following people are most likely to develop disseminated disease? Say,
HIV.
otherwise healthy individual. Fourth semester Cairo student. Or perhaps an allograft recipient.
The last one.
The last one.
Yeah. Oh, yeah, I can't even say. I don't even know what that is.
So an allograft recipient,
Yeah,
they'd be on immunosuppressant.
yeah.
Yeah.
All right.
Don't use the word without telling us what that is.
What word would that be?
The word you just said.
An allograft recipient?
Automatic can't be them.
You know it's
have I been
immunocompromised.
cruel? Allograft recipient. I'd probably say something like the person maybe on steroids
Mhm.
or something like a heavy immunosuppressant.
Okay.
I'd use allograft for a bonus question. No. Not even that.
Someone that got a brand new kidney or something.
Brand new
Just out of
kidney.
nowhere.
Spanking brand new kid. Okay, any questions on this? Okay. That's it for today.
Can you repeat what you said last week? You said heavy,
No, you said it's enough for today.
immunocompromised, steroids, and heavy what?
I said someone on it, like on steroids, some sort of immunosuppressant. Maybe they have an autoimmune disease.